Thanks very much. It's nice to be here. Thank you very much, Natalie and Shaz, for inviting us, and thank you for all the hard work you put in on this very well-attended meeting. Speaking mainly to a group of ME families and sufferers, even though I know they're doctors in the audience, I always feel constrained to apologise on behalf of the medical profession, so I've apologised, okay? I'm sure you know what I mean. I have a particularly unusual take on this illness because I see it through one end of the binoculars. I'm quite willing to accept that things are going fine in lots of parts of the country, that some paediatricians are handling cases beautifully, and that some of the ME units are doing good work and everything. But I have a particularly biased view because all the nasty cases seem to come to me. And I've got quite a wide experience of the actual numbers, so I've seen over 600 cases of pediatric ME in my time. The cases actually taken to child protection proceedings number over 35 now, and I have five possible cases on my books this week. So if anyone says it's all got better since the film, it's not true, and there's new cases coming in every day. And they're all just the same old story of disbelief, pressure from education, failure of the paediatrician to be clear enough about a diagnosis, and sometimes a nasty social services counterattack against someone who's been asking for help. The other ME charity unusual one is they've actually asked me to be the medical advisor to the 25% group, which is Simon Lawrence's. And I think the fact they have to ask a clapped-out retired paediatrician to be their medical advisor is very sad that they don't feel there's anyone else who they feel can understand severe ME enough for them to trust. And I'm happy to hand it over if anyone comes forward. And through that agency, which is not paediatric necessarily, I've seen the severe end of the reality of this condition. And here I do feel critical of our profession, where you see people who have not seen a doctor for 5 years, bedridden at home, cared for by their parents. The GP doesn't visit because they're not well enough to come to the surgery, and there's no consultant in the local hospital willing or interested enough to take any responsibility. I had a case in Northern Ireland, tube-fed on a ripple bed, catheterized, looked after for 5 years by a GP. And we tried to get the consultant in the local hospital involved, and none of them would touch it with a barge pole. So that is real medical neglect. I'd just like to say a brief thing about a study I did in North Durham before I retired. And we did 49 cases. And the value of this study is we looked at all grades of severity, including those who were really quite mild, and it gave you a very good feeling of the spectrum. And this was the days before graded exercise, multidisciplinary approach, and all those things. So I just gave them sympathy, support, common sense advice. And the very severe cases, because I felt I had to offer them something, and there was some evidence for immunoglobulin, I actually gave immunoglobulin to. Those were the simple grades of severity that we used to assess them. And at the follow-up, my management approach was firstly validation, showing you believe in them and that you accept it as a medical illness. I used to hand out NHS prescriptions with the word sympathy written on, because it's cheap and doesn't cost anything. There's lots of things you can do to support children with ME. Letters for home tuition to the Education Authority, advice on amount of schooling. As you'll see from the kind of horror stories we've talked about, actual diagnosis and following them up and keeping them under your care and protecting them. And there wasn't one case of care proceedings in the northern region during the 25 years I was a consultant. Using the local support group is very valuable. And I want to say a bit more about immunoglobulin later. Tube feeding for severe cases, and common sense advice on activity management, which probably was compatible with a pacing approach. And I didn't include these things. I didn't refer any of them to psychiatry initially. I referred 2 on the parents' request, and both consultations resulted in a formal complaint from the parents because they were ridiculed and treated with contempt. So I didn't use psychiatry very much, and I didn't actually need to because most of my kids weren't depressed and had an organic illness. I didn't use a physiotherapist. The mild cases didn't need it, the severe cases needed protection, and the parents would use very gentle, passive movements under instruction. I didn't use hospital admission except as an absolute last resort, maybe to get tube feeding or a peg gastrostomy. I didn't use a multidisciplinary approach. When I first tried it, every new discipline I introduced said something discordant and upset the family, and we had to kind of protect them. And my very last severe case handled with the GP, the dietitian for the tube feeding, and I used immunoglobulin and antibiotics in case it was Lyme disease, and she was the most severe case I'd ever seen, and she made a total recovery in 2 years. I'm not claiming the credit for it, maybe she was just lucky. And I didn't use CBT or GET, which I'll talk about in a few minutes. This was the results of the ones who did better. These are 15 of the 49, nearly a third, and you'll see that quite a few of them were in the moderate, and one was down here in the severe group, and they still had quite a long duration of illness. So these people who say you'll be back at school full-time next September, there are very few people you can say that to. In fact, I don't predict the future with any of these cases. But I found that reasonably optimistic that with minimal intervention, these people got better spontaneously without being made worse. Because we don't have a cure, I'm going to keep stressing, some got more severe. And there were 7 at the end who were in the severe group. I'm glad to say that my knowledge is that most of them have since begun to improve. But this was a very interesting boy. No one knew he had ME for the first 3 years. But every time he got a virus, he was off school for a month. And he had all these dips all the way across for those 3 years. And he was off school with typical ME symptoms. And I think undue susceptibility to virus infection should actually be one of the cardinal features of this condition. And then he went, because he didn't know he had ME, he went backpacking with his father in Scotland, camping, carrying tents. And that's when he went down. I should mention another girl I had, not in this series, who is at 90% attending school full-time, off sport on her paediatrician's advice, who was tricked into doing a cross-country race by the teachers because they remembered how good she used to be at cross-country. And that race resulted in a severe relapse, and she was off school for 18 months. So Mark stressed, we all know the damage that overexertion can do, and that was one episode producing an 18-month relapse. And then the large majority were in between. But again, this is a severe case, tube fed for 3 years, who is now working in the post office. So even the severe cases are compatible with good recovery, and most of them were still hoddling along in the moderate category. So firstly, it's a very unpredictable condition. You saw how those relapses and remissions shot up and down, wide fluctuations, grounds for cautious optimism overall. I think we all know that the prognosis in children is slightly better or more optimistic than it is in adults, but still don't underestimate it. Even mild to moderate ME needs to be treated with great respect. We could talk about the evidence base for management at great length. There's loads of stuff written. I don't find much of it very helpful. No one has ever studied the severe cases, and lots of people, as I've said, ignore them anyway. The reality of the severe case we need to keep remembering. There's no evidence that we have a curative treatment. I hate people using the word they have a treatment regime. You've got to come into our unit for treatment. You can talk about management by all means, and we can debate management, but treatment implies a cure. And no management is so efficacious that it justifies coercion, full stop. When I was on the CMO's working party, they did a literature review, the York Centre, and they looked at all the reviewed, the RCTs, and they found only 3 forms of management that showed overall efficacy in more than one study. The first was immunoglobulin, the second was cognitive behavioral therapy, and the third was graded exercise. Would it surprise any of you to know that the CMO's report excluded the first and only mentioned the second 2? I cannot think of a clearer evidence of anti-organic bias than to suppress the evidence on immunoglobulin. And as I said in the film, if we'd believed in this as an organic illness for 40 years, we would have done more trials on immunoglobulin, found out if giving it early was more effective or not. And I've rediscovered an interest in and faith in immunoglobulin, which I think we should reconsider. But it was actually excluded from the written report. The trouble with graded exercise, and also with CBT, is it can cover a multitude of sins. Okay? It can be a rather Germanic, rigid, it's irreversible, 10% more each month. And if you get worse, you've got to push through the pain. As Mark says, we all know that's rubbish. But some proponents of graded exercise believe it's true. I hear time after time of a pediatrician who said, go back to school and push through the pain, you'll be all right. It's still happening. Okay? And I don't think the research, I'm not an expert on it, but I'd be surprised if the research on graded exercise actually tells you what they mean by graded or which variety they've been using. I'm willing to believe that a gentle pacing type regime, which allows for reduction if you overshoot, will actually be beneficial. And that is cautious and it's sensible. And that's really what I followed. And lots of the patient groups all prefer the label pacing. CBT can be of two varieties. It can be a common sense, pragmatic form of advice, where you could say, actually, I think in retrospect, that going to that pop concert in Glasgow might be the reason you've been bedridden this week, which is gentle throwaway therapy, take it easy. And a more psychological approach, and this is very common, that if only you can get inside the patient's mind and eradicate that belief that it's due to a virus, you have automatically improved their chance of recovery. Now, until you hear what the psychologist giving the CBT was actually saying in the privacy of those consultations, I don't know what kind of CBT they've been getting. And I know which I'd prefer. The paradox is the ME community are desperate for some form of treatment, cure, and they're extremely dubious about the efficacy of CBT and GET, and they prefer pacing, and they don't appreciate having these therapies forced on them. Of course, for adults, that's fine. They can just say, thanks, don't call us, we'll call you. As I said in the film, it's different with children. Parents don't own their children. They belong to the state. And if the state wants you to have treatment, the parents shouldn't get in the way. And of course, there wouldn't be a controversy at all if there was a cure for ME. We wouldn't be here. We'd all be cured. So we don't have a cure. I do find that one of the biggest problems is that some doctors cannot tolerate patients not getting better. I always say if the patient has to tolerate not getting better, it's the least the doctor could do. These are they call the dangers of the therapeutic fallacy. I'm not just against CBT and GET of the varieties I've talked about. I'm against inpatient rehabilitation. I saw 3 brothers with common or garden ME in Lancashire last week, and they are under threat of a court order to go into a psychiatric unit in Liverpool for compulsory 6-week physiotherapy and hydrotherapy, and mother's not allowed to visit till 4 p.m. Now, where does that come from? Let the physiotherapists have a kind of free hand for the day. And that is actually happening this week. So I'm very allergic to rehabilitation. It sounds such a benign word, doesn't it? And then, if you believe in your therapy and the child doesn't get better, it must be the fault of the parents. First World War generals. Or you got the diagnosis wrong, and it's mutated from your first diagnosis of ME, and they've got worse, so it's something else. So it's either the mother's keeping them ill, Munchausen by proxy. I still like that term, although people try to abolish it. It does exist. I've seen 2 cases in 30 years. It is as rare as hen's teeth, and ME is very common. And the worst thing is this pervasive refusal syndrome. It is a real syndrome, very rare, very severe. The child is almost wanting to commit suicide by pulling out drips and pulling out tubes and total non-cooperation. And a child with pervasive refusal syndrome can look very like a child with severe ME. Except the child with severe ME had mild ME and moderate ME that got worse and didn't suddenly turn into pervasive refusal syndrome. It is, of course, possible that you can have both. And withdrawing from our treatment equals child abuse. I saw a 12-year-old boy in southeast Scotland who was tried the program that was guaranteed by the local paediatrician would give a 100% chance of cure in 9 months. and it involved activity management and waking up at 8 o'clock and timing everything. He actually got worse on the treatment. The parents said, thanks very much, can we withdraw? The paediatrician started child protection proceedings because refusing medical advice is child abuse. The fact that the medical advice could be rotten didn't seem to occur to her. Actually, NICE guidelines, which people have been pretty critical of, are quite benign. It's how you interpret them. And there's nothing in NICE guidelines that stresses the treatment is enough to justify coercion. And it talks very much about informed consent. And they stress quite clearly there's no evidence that CBT and graded exercise are effective in severe cases. And yet, time after time, I see a paediatrician confronted by a severe case who goes mad and says, oh, well, it works in mild cases, we've got to do it in severe cases. My favourite joke story is the boy from Australia who was 14, son of a doctor, got ME, went right round Australia for a year seeing all the experts. And they said, you must have found out a lot in this year seeing all these clever doctors. He said, not much. They don't understand it at all. He said, there's one thing I've noticed about it. It's a condition which induces an acute emotional disturbance in doctors confronted by it. Just say a few things about managing severe cases. My first severe case, I did panic. I sent them to Newcastle. I got multiple second opinions. I over-investigated. She never forgave me. She never forgave her parents because I'd promised she was only going to Newcastle for an afternoon. They kept her for 3 days and frog-marched her and did lumbar punctures. So I realized that unless you can really trust the person you're asking second opinions for, you can damage the patient's trust in you. It's a very challenging area. There's no worthwhile evidence. It's dangerous to extrapolate from studies on the milder end of the spectrum. All the studies on GET and CBT on ambulant patients, and these are bedridden. And the natural response is to panic and to be scared you're missing something or that the patient's going to die on you and someone's going to complain. And this is what they look like. Total body pain, hyperesthesia, the mother's trying to turn them and say, oh, it hurts, mum. And then hatred of light, smells, everything else. And they can be too weak to eat and drink, so they may need tube feeding. They have these muscle spasms, and they can start with hypersomnolence, which then goes on to sleep reversal. And I had one girl who slept 23 hours a day for 9 months. That changes. It's one of the nice things to say, well, actually, you're now at a slightly more convalescent stage because you've got sleep reversal. Pity you can't get to sleep till 4 a.m., but it's still progress. This is a girl who comes from Sussex and was the subject at the age of 18 of a High Court wardship with a very, very high and famous judge. And the lady paediatrician in charge of this case, this was about 10 years ago, assured the judge that if she had a wardship and could admit the child to her hospital, she would give her such treatment that she would be walking within 6 months. And the judge believed her and gave an order, and she was admitted. I was trying to oppose it, and I was overruled. She was admitted and given daily physiotherapy for 3 months. And the poor little girl finally won some small moral victory by telling the physiotherapist that she thought she was in breach of her professional guidelines to be imposing her treatment on her against her will, and the physiotherapist backed off. They kept her for 3 months because they didn't know what to do. They couldn't send her home because that would mean they'd lost face. So they said she had to go to another inpatient unit. They let her choose, so she said Durham. And she came all the way to my unit in Durham, quite unnecessarily, just to save the court's face. And we had her for 6 months, during which time she was totally traumatized by what had happened to her, and we had to treat her with TLC. And even though I gave my nurses talks about her and everything else, they started doing all the things that Naomi says in the film, why don't you want to get better? And, reporting me to the child protection person because I had this girl in bed. I mean, it's crazy. You can do your best to educate people, and finally a nurse said to me, so you're really telling us that everything we're taught about nursing is the wrong way round for this condition? I said, right, yes, all the things you're taught, counterintuitive, do the opposite. She was tube fed for a long time. She eventually got home. I heard today of a paediatrician actually saying that a patient couldn't have ME if she was tube fed, which strikes me as a bit, what should we say, counterintuitive. So this is what I would advise another paediatrician in charge of a severe case. Don't panic, do no harm, share your uncertainty with the family, talk about possible approaches like immunoglobulin and things like that, take it or leave it. Keep checking, get a nice, gentle second opinion from someone you trust. Resist the temptation to over-investigate. Keep at home, because home is far more suitable for the very severe case, and resist the urge to rehabilitate. You all saw the film, on the film, Emily Collingridge, who died last year, a year ago in March 2012. She was operating at home, like all those cases in the film, 1% functional capacity. And I said, if one thing makes her a bit worse, she will die. She got a renal stone, went into King's College Hospital, died of ME in a teaching hospital 6 weeks later. So they do die. And above all, resist the urge to rehabilitate, tolerate the disease. Treat symptoms, tube feed, gentle physiotherapy. I never actually gave heparin to them. They seem to move around enough. I've never seen a pulmonary embolus from them, and try and give them one particular community nurse and maximal TLC. I've mentioned immunoglobulin. I went to a conference in Australia where I heard about Garth Nicholson and all his work aimed at atypical mycoplasmata, and then I went to a conference on Lyme disease. I'm very interested in these atypical infections. And as I say, the last case I seemed to cure was because improved from the time I gave her doxycycline. So whether that treated a mycoplasma or not, I don't know. Rituximab is still being tried again. I looked at my very severe cases, and 5 out of 7 needed tube feeding, and as follow-up, 4 out of the 7 had made a complete recovery. My first case was given immunoglobulin by Dr. Speight without my knowledge or permission, and cured him. And 2 years later, that boy was head boy, playing rugby, and climbed Snowdon, Scafell Pike, and Ben Nevis within 24 hours. He had a slight relapse at university with flu, but then made a full recovery. And I dated from the time he got immunoglobulin. I've always felt that the severe cases are one of the best arguments against the psychological view of this illness. To actually have a severe illness that much, and you expose them to a psychologist and talk to them, you should be able to find something. They're either being severely sexually abused or traumatized or something. But never found anything, and they recovered. So it just, even the moderate cases in childhood convinced me that it's a genuine physical illness. That's one of the recoveries. She had 3 years bedridden, tube fed. These are the 3 of the studies, and 2 of them you'll see had a positive effect, and one of them was actually in children, I think the Peter Rowe one. But why hasn't more research been done on immunoglobulin? I don't know. I have been critical of my profession, but these are all things that I've heard from GPs or paediatricians. We don't believe in ME in this practice. That's even post NICE guidelines. Well, if it's got NICE guidelines, it must exist, mustn't it? Children don't get ME. He's too young to get ME. He's 7. I've seen it in under 5s. I don't like labeling cases. I don't like diagnosing things for which we haven't any treatment. I thought our medical training taught us to deal with... and this is the best. This is from a professor of pediatrics to a 6-year-old girl. You can't have anything wrong with you as all your tests are normal. And the little girl said, maybe I've got an illness for which you haven't yet invented the right test. And maybe Mark has now invented the right test. How are we going for time?
5 minutes.
I'll just give you this archetypal case. There's Tiffany, 14-year-old girl. A lot of my child protection cases have been targeted on single mums, which is understandable, I suppose, if you're a social worker looking for a soft touch. And this poor mum, they targeted her. She behaved innocently. Tiffany got severe ME, was hospitalized. She had to be hospitalized for nursing care. And once she was in, she was under a nice paediatrician who believed in ME, who'd handled plenty of moderate cases as outpatients, and I thought she'd be in good hands. Unfortunately, there was a multidisciplinary team. And this multidisciplinary team met weekly and had a regime. And the paediatrician was pushed out of the way. The multidisciplinary team was a community paediatrician and a consultant child psychiatrist. And these meetings, which Tiffany had to go to in her wheelchair with her head like this, she had to agree to the targets for the next week. And the nurses were left her to feed herself and the food put out of reach so that she'd have to make an effort, because we needed, it was all weakness of will, and her mother would often find her dribbling food, sitting like that, and she'd gather her and put her back in her bed and draw the curtains round, and the nurse would say, "Mother came," Tiffany burst into tears, mother making her cry. She got steadily worse. I'm sure none of you are surprised at that, but she didn't get, because she was getting worse, mother must be sabotaging it. So for the next 2 months, mother wasn't allowed to come till 6 p.m. And they carried on with the physio. And she got worse. And the First World War general said, "Oh, no, we must keep you." But the benign paediatrician said, "No, we're not doing much for you. Why don't you take her home?" So she took her home. But the nurse made her sign against medical advice. Then the lady GP came in. I've described a new medical syndrome, actually. It's called the frightening lady doctor syndrome. And this lady insisted on talking to Tiffany on her own when she was feeling absolutely awful and reduced her to tears. And then she rang social services, said, "I can't accept responsibility for this child." And so the social services immediately promoted her to Munchausen by proxy, came with police and took her back into hospital. Okay, and then because it was Munchausen by proxy, the mother only had supervised access to her daughter. And when Tiffany cried during mother's visit, the social worker said, "If you do that again, we'll stop your mother's visits altogether." I was called in by the guardian ad litem, the independent social worker, and I found Tiffany demoralized, totally despairing, and I asked her if there's what did she want me to recommend? She said, "Well, if I'm only allowed to, my birthday next week, could I possibly see my mum without the social worker there?" That was the only thing she could hope for. She was resigned to going into foster care for 6 months, where, of course, being Munchausen by proxy, she would have recovered. I said, "I think we can do better than that. Call your guardian and tell them what you think." And she instructed her guardian, and I empowered her, and she won her own case. She's now 100% recovered, went to university in Cardiff, and is a brilliant girl. Her mother came to Downing Street under the last Prime Minister but 2 and told the story there. Still goes on though. This is an archetypal case. So in conclusion, I believe, I always have, that ME is primarily an organic illness which can affect patients who are initially psychiatrically normal. I'm surprised they don't get more psychologically abnormal with this illness, but they don't seem to. Currently we have no cure, and for too long this area has been left to psychiatry, mainly because no ology will accept it. If you look at a general district hospital, none of them want to see it. The neurologist doesn't. Sometimes a kindly rheumatologist might. There isn't an infectious disease one, and that's why the severe cases are left alone without consultant care. Worth further trials of immunoglobulin and rituximab, possible further research for infective causes. Obviously, it'd be fantastic if Mark's study gives us a clear, acceptable biomarker of a test that we can actually say this patient definitely has this condition. We should face up to the existence of the severe cases and accept responsibility for them. Melatonin for sleep reversal. I actually tried Ritalin for brain fog on the grounds that some of my people were very like ADHD. They get a kind of acquired ADHD. It seemed to help. We had a girl who slept till 4 p.m. before her home tuition. We'd wake her at midday, give her a Ritalin, and she did very well on home tuition. So, that's all. Thank you very much.